on my presentation. My name is Anca Copescu. I'm the founder and CEO of Strategic and Pharma. And I spent most of my career between clinical outsourcing and vendor management for sponsors and strategic business management for the CROs. So I really enjoyed your panel. Thank you so much for your insights. My topic is quite related. I'm trying to take a different spin to the discussion at hand, which is looking at other considerations for remote clinical trials. And those considerations are more on the business side. So what I will be talking about is the impact that technology can have in modeling different protocol scenarios, considering entirely decentralized, hybrid, classic, different forms and shapes of remote clinical trials. And my focus is entirely on the business side in terms of planning and particularly budgeting and evaluating impact of various decisions that you make before the trial execution. So with that at hand, I'm going to get started. I want to ask if you can see my screen. Okay, so let me go in slideshow. And I'm going to get started. So first statement I'm going to make should be of no surprise to you. That is, most pharma companies, and for that matter, CROs as well, use Excel or some kind of generic solution to manage clinical planning and budgeting. But as I was much enjoying in your panel discussion today, planning for a remote trial or decentralized or hybrid trial is a completely non-trivial exercise. And because of its non-trivial nature, Excel is not always the best tool to really quickly give insights on the cost and timing impact of decisions, which is decisions related to the execution of the study. And most companies are really going 300 miles an hour, looking at different solutions to enable the conduct of remote trials. But truly very little has been invested in improving the technology aspects of the planning and the budgeting. In my view, there is a very high cost of doing nothing. And by doing nothing, I mean trying to plan and evaluate scenarios and negotiate with CROs on the basis of Excel. The negotiations tend to be lengthy. They lead to costly trial delays, particularly due to poor planning and not a full understanding of the impact of doing, path A versus path B. Not to mention the budget overruns that the change order volume tends to be much higher in trials that are using let's say, a newer approach, and particularly hybrid approach. And there is a lot of confusion over, what is lost and what is gained by, using home nursing versus a classic CRO. And is the classic CRO doing the same job, or what does it change in terms of the ratio of coordination and all of the business and outsourcing aspects of running such complex trials? Of course, trying to do all of this work in Excel inherently leads to unscalable infrastructure. First, because we don't have a lot of know-how and experience in this domain. So as you can imagine, poor planning or kind of back of the envelope planning has serious consequence. But most importantly, because we are starting on this whole new journey of looking at very different trial designs, if we don't memorialize the history of how we are doing, then we can learn very little of the experiences that we are having. And what really caused the change order? What could we have done better in planning? And there is a lot of volume, but there is very little centralized intelligence around the business aspects of running remote trials. And primarily, my assessment of the root cause is what I mentioned at the top of the meeting. It's because there has been little to no investment in technology that supports the planning and budgeting of these complex protocol and alternative development models. Well, I am truly hoping I'm the bearer of good news here because technology is coming. I'm thrilled to talk to you about Clinical Maestro. This is a technology that we have started developing 3 years ago. It's entirely focused on the business side of clinical trials, and it's a suite of modular solutions. So you can see we have a solution that is specifically tailored for planning and budgeting and running any number of what-if scenarios, with the goal of bringing intelligence in the planning and budgeting, bringing speed, the memory of and the business intelligence that comes with technology, with the ultimate purpose of accelerating study startup, and of course reducing the overall cost of trial through better planning. We have another solution which we call Source, that is essentially importing the plans or the scenarios, the preferred scenario that it's going to be outsourced, and it's automating the process of outsourcing that remote trial. Why technology is important there? Not that we haven't done RFPs in Word and Excel for the last 30 years. It's because the data, the intelligence data from portfolio automatically migrates into Source, giving the sponsors tremendous leverage in negotiating with the CRO. So instead of throwing a protocol over and say, dear CRO, please propose me a plan, and give me the alternatives and the impact of your plans, which rarely happens. The sponsor goes into the bidding process, whether it's competitive or non-competitive to a strategic partner, with a clear path forward and a very good understanding of the impact analysis, which overall reduces the cost of outsourcing. Then, of course, the outsourcing is just a precursor to running the trial. And it's equally important to look at the performance of all the vendors on the trial, depending on the model, whether it's a classic CRO model or multiple CRO model. If you are bringing in home nursing or RBM technology or any other service provider on your trial, needs to be tracked with the purpose of reducing the number of change order and truly understanding the performance of your partners on a clinical trial. Our third module is planned for release in 2022, is actually a governance tool that is designed to bring insights at the portfolio level, looking at both clinical, financial, and vendor management aspects. The idea of designing such a technology is not only to address the shortcomings of working in Excel, but also to allow that Excel experience to some extent. That means we designed the tool that you can leverage the technology to get to faster outcomes, but you can easily export data out of the solution in Excel format if this is your preferred or established way of working. Of course, these modules work beautifully in concert. That's why we call the solution Clinical Maestro. But more than anything, they can be deployed as standalone. So if what you are looking for is better planning before you initiate a sourcing project, then you can use our portfolio solution and still do the RFP, in Word or Excel. If you want to go to the next level, then you can automate that process. And the idea is to have technology penetrate in a continuum. So you can, at the end of the day, improve all the aspects related to the infrastructure side of clinical trials. And of course, more than anything, we are working in an environment of systems. So connectivity to other systems, being able to pull data from different sources, whether you plug it directly into another system or you get the data from a data lake, and those insights that would allow you to gain insights into the overall performance and health of the trial from both a business and an operational perspective is essential. What I would like to give you some insight, I only have 20 minutes, but I want to give you some insights into how you can better plan and budget clinical trials in a remote setting. So let's talk a little bit about the options or the considerations that you should have when planning a virtual and remote trials from a business and outsourcing perspective. So we all know the classic multi-site. And the costs associated are not meant to be all inclusive, but the major category are the monitoring, whether on site or remote. It's the site management, the project management, the vendor oversight, which is an internal function, and of course, all sorts of technologies that support the execution of the trial. If you're looking at a classic site with risk-based monitoring technology, this is a booster with, in our view, yet not entirely quantifiable savings, but of course with significant benefits in terms of data quality, as the panel just discussed. Of course, we're still talking about multiple sites. It's applicable to most indication. And when you're looking at the cost impact, typically it's less on-site IMVs, but central monitoring is also quite intense and oftentimes offsetting the cost of travel for on-site monitoring. There is also reduced time on site naturally and the travel cost. But at the end of the day, the softer element of the RBM, it comes into greater compliance and of course, more efficient vendor management and vendor oversight on the trial. When you deploy the RBM, of course, you have the licensing costs associated with the technology and the data connectivity with other systems. And now when you're looking at the costs associated with decentralized trials, whether it's fully decentralized or some kind of a hybrid model, you may have few or no central sites if you are looking at an entirely decentralized study, but of course this doesn't work everywhere. This model is not fit for all indications, as the panel was just discussing Parkinson earlier. The cost impact is again quite interesting because on one hand you are saving on some of the CRO and site management costs, but on the other hand you are implementing home health, which is by no means a cheaper alternative. You're looking at in-home logistics, you're looking at about equipment provisioning. In general, you have a lower cost with managing fewer sites, but the trade-off is, of course, the technology support for remote visits. So what I would like to do is give you a very rapid glimpse, let's say, into how you can achieve this type of modeling with technology. So I am virtually logging in Clinical Maestro here to show you a screenshot. This is our technology platform, and the modules I described before are at the top. So portfolio for planning, source for RFP management, lead for management of the study post-award, and then provider management. And what you are looking at in here is a fake study. Obviously, I must say none of the data is real. That has 3 scenarios. The scenarios we are looking at are a baseline country level scenario for about 1,000 patients and 200 sites, and this is a classic study. The second is the classic study with the RBM, and the third one is an extreme decentralized scenario, which is the 1 site going down from 200. If you are looking at the overall technology of the overall cost, it appears that the classic is the more expensive. I don't want to generalize this because it really depends on the assumptions of the specific scenario that was built, and some scenarios may not yield this outcome. The idea of this illustration is to show you how easily you can compare the impact of these 3 solutions. Looks like decentralized is the lowest cost, but again, in a different scenario, in a different trial, these numbers can be entirely different. What I'm trying to get to here is the ability to easily see the impact of this scenario. Of course, you can dive deep into each. And given the time constraints, I'm only going to look at the remote visits component, so you can have a better idea of how this can be done using a system. So I am going within this scenario at the site visits tab. And if you can see here, just at the very high level overview, this is a study which has 2 countries, it's US and Canada. And all of the assumptions of the study are on top. So these are patient, patient sites, timeline, central assumptions, services. But what I'm looking here right now is simply playing with the assumptions on the site visits. My starting point is that we have 100% SQV rate, and I'm going to have for site qualification visits, we do the site initiation visits 100% in person. We are doing source data verification at 100%. Using a classic assumption for the number of hours review per page, which of course differs by indication. This is the assumption we made for the study. All of the IMVs are in person. So in fact, in this particular model results in about 850 IMVs all in person. So let's take a look at how you can play with the settings in the application. So you can make changes at both global level or at the country level. So this is an example in which we are looking at the global level, and we have decided to have a mix. So in this case, we took the 34 visits and we said, well, we want to have only 6 in person and 25 remote. That results in a 1935% rate of in-person, and we're changing the site initiation visits as well. We are saying, well, only 50% of this would be remote. We left the SDV rate at 100%, but we could have reduced that by quite a bit, that you'd see the impact of that scenario very easily. But we try to, in this model, we try to isolate one variable, which was remote versus in-person. But of course, any of the assumptions can be changed. So that was dropped to 30%. You can play with the settings not only at the global level, but you can have a country-specific strategy. So I want to show you the next image in which the blue bar moved to Canada is because we are using different assumptions from Canada and US. And this may just as well be the case in real life. So in this case, we made 0% in person in Canada for site qualification visits because maybe we already know the sites. And we used a different percentage for site initiation, and we kept the same percentage for the IMVs. Again, what I'm trying to demonstrate here is examples of how you can play with assumptions. In this case, we're only changing one variable, but I could have changed the number of hours per page. I could have changed the number of hours on site for data verification. That would have resulted in a totally different number of IMVs. I could have changed the SDV rate, but we're looking specifically of isolated one change. So let's take a look at what this means. So after you make the changes, you can easily compare the scenarios side by side. So you can see I have these 2 scenarios, and I can easily see what the differences are. So, we only changed one variable. So we went from 60 to 100. And we haven't made any changes in the IMV assumptions other than we changed the percentage of in-person versus remote. So, of course, the question is, well, what does it mean? This is an example that does not have a big impact on the timeline. Of course, other changes that you would make would have an impact on the timeline. In our case, because we focused on only one assumption modification, we looked only at the cost of doing the site qualification and the site visit remote versus in person. You can see here the impact is quite significant. So it dropped overall from $40,000 to $80,000 in this scenario. This is another example, again, not sufficient time to do a deep dive, but we are, of course, available for follow-up questions, meetings, and additional demos. This is an example of a classic versus remote with RBM, in which all of the assumptions have been changed to tailor to a remote with RBM model. So these are significant changes here. You'll see that biostats and programming has not been very much impacted in this model. But the clinical data management is, in this particular case, is a difference of about 15%. And this has to do with various assumptions that were made in the RBM model. So the cost went up. If you're looking at clinical study management, the cost went down by quite a bit, and this is primarily because of the site visit and improved oversight. And again, this is to get a helicopter view. We don't have sufficient time to see all of the changes that were made in this scenario, but this is an essential tool for a clinical project manager, for clinical study management, for financial management in a pharma company, the ability to evaluate the scenarios before you go to a CRO and initiate negotiations, and actually leveraging whatever scenarios you have planned during the negotiation is tremendously valuable. So let's take a look at some of the RBM cost drivers. Again, not sufficient time to show you a full modeling with RBM, but these are the things you should have in mind. It's the setup and the data connections tends to be a pretty significant cost in RBM. It really depends on the landscape, the digital landscape of the sponsor or of the CRO if you are deciding to leverage the power of RBM through the CRO. Of course, it's the data analytics engine, which is a major cost driver, and the creation of the patient profiles. If you are looking at the major cost drivers for decentralized trials, well, really you are looking at home health. Home health has been around for quite some time, but has never been in more demand than it is now, which of course, at least during this period of time, makes it quite of an expensive service, also because of the shortage of nurses in the market and challenges in running global trials in this decentralized model. Equipment provisioning, it's something that you should consider, and that really means an electronic equipment, whether it's an iPad, an iPhone, both, depending on the study design. The equipment has to be provisioned, it has to be set up, it has to be sent to the patient sites, it has to be collected, monitored, so that's a pretty big expense. And that is, of course, it's all the other investment in remote technology, anything from e-consent to various software solutions to better execute the trial. So this is, again, a helicopter view of a study in an extreme scenario that I was showing you before, going from 200 sites to 1. So obviously, it's actually not an entirely unlikely scenario, but let's say it's an extreme scenario. A hybrid would have been more likely. All I'm trying to do here is point out the differences at the top level. Of course, this is a slide, but if I, double click here on clinical data management in the software, you would have seen the impact detailed down for each category. You would be able to highlight differences and so on and so forth. But let's take a look here. There's not a big difference in the clinical data management. In this is a scenario without RBM in this case. But look at where the costs are swapping. It's really between the CRO, which is the clinical study management, and the home health. So if you're looking at saving 29 million on the CRO, and it's heavily on the project management side and site management, but you are putting the money basically in a different pocket for home health. Again, this does not include all of the elements of consideration for a decentralized trial. This is meant to be a high-level discussion to give you an insight of what you can achieve using technology. At the end, towards the end of my presentation, and I want to talk about the return on investment of using technology in planning. You heard me talking about the importance of having what if scenarios and impact analysis. There are so many considerations and so many assumptions you can tweak. We were just playing with a single percentage of, remote versus in-person site visits, but there are so many considerations and services that come in and out of scope that have impact on the timelines, that have impact on the overall cost, they have impact on your outsourcing strategy. So it's critically important to be able to run these scenarios and not entirely depend on the CROs to run them for you. even if you are in the deepest strategic relationship, that dependency weighs heavily on the oversight. Then, of course, it's a matter of speed. We have been measuring, and we had a webinar about a month and a half ago in which one of our customers spoke about using Clinical Maestro and reducing the number of hours to develop a clinical plan and budget from more than 100 to 12 minutes. I think I don't need to make any more comment on this because the reduction is staggering. And think about what happens with the other 88 hours. Well, it's actually, if it were 12 hours, it's 100 hours that are available for your team to do better oversight, to be doing better analytics, to be using their skills in high value added activities rather than trying to run budgets in Excel. Of course, the element of control and transparency, it's critical. It's essential to be able to run the sourcing projects, let the CRO propose their solutions, but have a plan at stake. And we have various options in our RFP generation engine in which you can simply ask the CRO to bid to your specs. For example, you would ask them to bid on the, full versus fully decentralized versus hybrid scenario. Or they could bid to their expertise and change their assumptions, but then you will be easily able to catch the differences and nuances by having all the data flying through a system that enables easy identification of differences, whether in cost, in rates, in effort, or in timelines or quality. I think I'm at the end of my presentation almost. I do want to bring the negotiated savings. It's quite important because through the leverage of technology and the presence of business intelligence, better planning and budgeting, we are seeing reductions of 5% or more on any given RFP. And, when you have a $50 million trials, these differences are non-trivial. But even on smaller trials, they can mount to hundreds of thousands. And I spoke about the efficiency of using your resources better. At the end of the day, I think we can all acknowledge that technology is a little bit overwhelming, especially with the wave of technologies that's coming to us post-COVID, and the challenges in navigating in a more digital world than before. For me, as a CEO of a technology company, it's thrilling to see this change and to see technology penetrating on the business side of clinical trials, and I'm thrilled that we are leading the path there. But we are also acknowledging that adoption takes effort on both sides and requires intensive change management. So we are standing with each implementation with really outstanding professional services. You can license the software, and we provide support anywhere from onboarding to watching over your shoulders on how you design these different models and scenarios for planning and budgeting or RFPs. We have an operator model in which if you don't have resources, we can put a resource of our own in your organization, and we execute on your behalf. It's a kind of a technology FSP model. But also you can do completely hands-off. That is particularly for planning, in which you give us your protocol and we will do this modeling for you. And it's more like a consulting business in which we would give you back a report. We have a very fast turnaround time because of the use of the technology versus Excel and pure labor. So with this, concluding my presentation, I hope that you enjoyed some insights into what you can achieve using technology for better planning of remote and decentralized trials. And I'm open for questions.
Yeah, hi Anka, it's Daniel from Bausch + Lomb in Berlin. Thanks for the very, very exciting talk. I've got one question. I mean, you demonstrated very well that if you go down with monitoring activities, if you go from a classical trial to a decentralized trial, so the costs will drop. That is all clear. But what I would be interested as a project manager is how can I reduce the cost by keeping costs and timelines constant? And this is what I'm really interested to hear from you. Maybe we can schedule a call, or you can comment on that, because to reduce the costs by reducing amount of SDV, I think that's not rocket science. But to reduce the cost and at the same time keep quality high and keep the timelines short, that is the rocket science. And this is, I would like to hear more your comments how your system can solve this question.
Thank you so much. This is a great insight. And I must say, Daniel, that this example, it shows a reduction of cost. But as we have been modeling decentralized trials, they are not necessarily cheaper. So I want to make that assumption, that clarification from the get-go, that certain decentralized trials can be quite complicated, and the cost of technology combined with treating patients of cost, it's sometimes exceeds the cost of doing it in a classic manner. But sometimes there is no choice there. To answer, go ahead.
No, that's clear. But what I was interesting, how do you measure quality and timelines in your system?
Yes. So quality, you can only measure it from the point of view of looking at your internal resources from oversight. You can measure quality. You can measure quality by having active performance. So if you look at what is quality at the end of the day? It's of course it's the quality of data. Yeah, it's the quality of data. You cannot get it from our system because it's a business management, project management type system. But what you can look at what you have contracted, the timelines you have contracted with the CRO or whatever, all of your vendors, not only one. You can look at how are you doing on certain metrics. So for example, are you enrolling faster? Is the startup time longer or shorter? There are so many assumptions that you can measure. This comes post award. So this is in our performance management application post award. What you can do is try to plan better. And that is also very important because you start with a baseline. But down the line, the tool allows you to do a combination of cost and operational metrics. And that's one element of quality. It's not the whole story.
Thanks a lot, Anka.
Thank you. Any other questions? I think there are some things in the chat, so let me see. Okay, so it says, how are your clients using Clinical Maestro in a real-life setting to plan or source remote clinical trials? Okay, this is a very good question. We've been seeing usage on planning and budgeting and sourcing together and separate, and I'll comment on that. The planning and budgeting, it's been more intensely used than the sourcing, but I think it has not much to do with technology, but much to do with the times that we've been living and many trials being delayed or more considerations being given before the study start. But the planning tool has proven to be really quite valuable. I've given you some glimpses of the scenario planning, but our clients have been doing all sorts of scenarios with different alternatives and really using it as a leverage or a dialogue starter with the CRO. So all of this would be, let's say, in the pre-start phase. In sourcing, we are seeing our clients create RFPs for different models. And as I mentioned in my presentation, asking the CRO either to bid to specs or allowing for their expertise to come through, but then holding them accountable on the expertise and saying, okay, well, we understand, we gain 2 months in time or whatever, X amount in dollars, but we are not seeing the time element, or sometimes the cost differences are quite staggering. So I must say there is a bit of volatility in costing here, which makes it exciting for us to collect the data and re-inject it in the planning. We have not used the system in a real life setting for performance management yet. This is just beginning right now. that is, we used it on classic trials, but not on decentralized trials. Let me see if there are any other questions. I think this is it for me. Maddie, I don't know if there are any other questions.
I don't believe there is. No, I do believe you covered it all, Anka. Thank you so much for your lovely insight and feedback. I must admit, this was definitely such a productive session. I've done plenty of webinars before, but this was definitely an interesting one. I'd like to thank you all for attending on behalf of World BI Group, our webinar in remote monitoring in clinical trials. Now, I'd like to say a huge thank you to our moderator for today, who was Asude Edemagalari. Thank you so much. Definitely was excellent. And a massive thank you to our sponsors. I must say our event wouldn't be as successful as it is without all of your support and sponsorship. So massive thank you on behalf of World BI Group. And a thank you to our expert panels, our delegates, and all our for today. So yeah, it was a lovely, productive session. Many more to come. We do have our future upcoming events, which we will email to you. So please do. Would definitely love to see you come along. They will be definitely interesting, and yeah, would love to send you the details. And thank you all so much. And I hope everyone has a wonderful day. So thank you from World BI Group, and take care, everyone.
Thank you. Thank you.
Thank you. Bye. Bye.
Thanks. Bye.
Thank you. It was a great meeting.